Welcome to the Health Tech Edge, the podcast on how technology is reshaping healthcare operations. I'm Mike Moore. Today, I'm joined by Jordan Ruch, CIO at AtlantiCare. AtlantiCare is in the middle of a pretty ambitious transformation under what they call Vision 2030, a system wide effort to rethink how care is delivered, how operations run, and how technology supports both. Jordan is leading a big part of that, including rolling out AI directly into clinical workflows and bringing together clinical and operational systems in a way most health systems haven't done yet. So, what we'll focus on today is what's actually working, what's not, and what others can learn from it. Jordan, welcome to the show.
Thanks, Mike. Happy to be here.
All right, well, let's get into Vision 2030 as a start. At a high level, what is AtlantiCare trying to change? What wasn't working well enough before that led to this kind of transformation?
Okay. Yeah, AtlantiCare Vision 2030 is very exciting. And it is part of what drew me to AtlantiCare. It's really about redesigning care delivery. And we're doing that through innovation, force empowerment, and community centered outcomes. So a lot of health systems have goals and objectives, they have their vision and their mission. The traditional operating models in healthcare we've identified are really no longer sustainable. So there are a lot of goals and metrics that are part of Vision 2030 that are directly tied to the community. So that's what's so exciting about it for me is they're not esoteric goals. They are directly aligned to the communities that we serve. And unlike many strategies that are, focused solely on internal efficiency, Vision 2030 sets explicit community facing outcomes like increasing life expectancy and addressing social determinants of health, alongside of all of the exciting technological advancements like workforce sustainability and modernization of all of our technology platforms that we'll talk about more today.
What's the reception been like from the community about what the health system is doing with this vision?
There's a lot of excitement. So patients are aware that we're undergoing this transformation and the journey. They have questions. A lot of patients' interaction with our health system is done through the patient portal. And our patient portal is being completely modernized from where it is today. So later this year, that portion of the program goes live. But our patients and our communities are excited about the investment and the level of investment that AtlantiCare is making into our platforms and into the communities that we serve.
That's great. Yeah, it's certainly if you're doing it for them, having them involved, having them aware of what you're doing, and like you said in your first response, why, right? What's the motivation for this? Especially there's so much cost pressure in healthcare today. That's a lot of what you hear about are cost-cutting measures and trying to reduce cost. And of course, the costs that are passed along to consumers, people of course would be in favor of that, but sometimes care is sacrificed or patient and member experience in the health plan side, especially so often sacrificed in cost cutting initiatives. And people are left sometimes with no other alternatives, right? And especially for their local community hospitals.
I think that's right. And, our work has been, to the extent we can, reversing that dynamic and making sure that we invest in areas that make the systems that we're using more efficient, to use one example. So giving back more time at the bedside instead of spending time doing documentation, or creating a better and more streamlined process to hire new nurses. All of those incremental changes add up to a health system that operates more efficiently.
So let's talk about your AI initiatives. I know that you've had some of your work in production for a while now, particularly around documentation, as you just mentioned. So do you want to give kind of a snapshot of what you've done and kind of what's in production today?
At AtlantiCare, we've been looking at clinical burnout and documentation burden, and that really was the forcing function for all of this change. There was a simulation study that was published in the Journal of General Internal Medicine that estimated that a primary care physician would require 26.7 hours per day to deliver guideline recommended care while managing documentation and the inbox while at work. So it's clear that that's not possible, and incremental optimizations aren't going to fix it. We needed to really reinvent how the interaction with our systems works, and not just make it incrementally more efficient, but completely fix the parts that are broken. So at AtlantiCare, we laid out all of the time spent in the EHR, and we've been systematically optimizing our current tools and deploying some new tools to directly address that issue. So the one you mentioned, Clinical AI Agent, is one that we've been using for a few years now. Ambient AI and ambient note writing is probably the area we've been using for the longest. And we have providers across more than 24 specialties that are using AI assisted note generation today. We've also implemented it in our emergency departments, and we have plans to extend that into our acute space later this year.
What's been the response from your clinicians about that, the tool and the assistance it provides with the documentation?
Yeah, the response has been significant and positive. There's two kind of major metrics that we track. And one is the amount of time spent in the EHR overall. So from the time you log in to the time you log out, and counting those times when you log in later in the day to finish your documentation, as well as the amount of time spent per provider, per patient doing just documentation. So we look at both of those metrics, essentially how much time you spend in the EHR and how much time you spend in documentation. And I think the response has been so great because we've seen a 40% reduction in documentation time and a 30% reduction in EHR time, which is incredibly significant. Provider feedback in general has been overwhelmingly positive. So we're constantly hearing that providers are able to focus more on the patient, less on the computer, which is exactly the outcome that we're hoping for. And really what, I've listened to many of your segments, Mike, and that's really what we're seeing across the board. A lot of health systems are seeing that same effect. Acceptance by the providers and how they like working with the tool is pretty universally positive. And I can tell you in my 25-year career in healthcare IT, that is not always the case. So very rarely do I have providers after you implement a system say to you, you could never take this away from me, right? Like this is something that we absolutely need to keep forever. And I don't want to ever hear you're taking it away. That's not, I can probably count on one hand the number of times that I've had that kind of positive feedback from the provider community. So it's been really great.
That's great. How about the response from patients themselves? Have you had any response from the community? Did they notice it? Do they have any trust issues? These are some of the things I think that other hospital CIOs worry about when you're considering some of this technology and coming in is, if I'm using AI tools in the exam room or in the clinic or in the ED, what will the response be? Are people open to it? What's the reality like for you and the team there?
Yeah, our reality has been that the thing the patient notice the most is that the provider's attention is on them. And patients that have the opportunity to have a visit with a provider that's using that technology and with a provider that's not using that technology can really see the difference. They see the difference because the provider is looking at them and engaging with them. And on the provider side, they're noticing maybe some of those nonverbal cues that they wouldn't see if they were just looking at the keyboard or looking at the computer and typing on the keyboard. So I think that more than anything else has been the patient's reaction is that, I really feel seen and I feel heard because I'm looking at the provider and they're looking back at me.
Yeah, I mean, I think we can all relate to this. We've spent time, as patients, or, if you're a parent of children, you're taking them so often. Maybe it's just the way some of these exam rooms are designed, but I know for my annual physical, I'm spending more time looking at the back of my physician as he's reviewing my chart and trying to put in notes and trying to add things to the record versus looking at the front of him. And we've also seen, I think, the folded paper that comes out of the pocket of the white coat and some notes are written on it. In theory, that goes back into the record at some point with whatever they're noting. But I think in general, this is one of the most popular areas of technology at this point when it comes to AI tools. So now that you've got the win, you've built trust with your users and the clinicians. Obviously, many of them, I'm sure you have broad age range of clinicians out there. So some of them have grown up digital, and others are maybe in the end stage of their career where they're adopting a new technology might be a little hard, but you've earned their trust. You're giving them a tool that's helpful. Where do you go next in the organization in terms of applying AI to the way that the system works, and kind of how you enable people with AI?
Yeah, it's really interesting when we look at the data. The use of this tool actually, in a way, raises the floor. And what I mean by that is our providers that were already really efficient, maybe they're using dictation and they know how to use the system really well, and their note writing is actually already pretty efficient with their templates. And like I said, they might be using technology to do dictation. Those providers don't see as much of a benefit with this technology. It's actually the providers that are least efficient, and it brings them up to the level of our most efficient providers, regardless of their technical expertise or their ability to navigate the system before the technology. That's why I tend to think of it as raising the floor so that all of our providers can be efficient. What we've seen is that what works well in a practice does not work well across the board. So we are really excited to get into nursing, and I think we'll talk a little bit more about that in a minute. But the same workflows that work in an exam room on the ambulatory side, they don't work in the emergency department. They don't work on the nursing unit in an acute setting, and they don't work in the OR. So we've had to be very aware of and working in partnership with our clinicians to really understand those workflows and figure out where the technology will best fit into their existing workflow instead of inventing a workflow for them to adjust to. That's how we've seen adoption be the most successful. So a good example would be in a practice setting. In the very beginning, it took a while for the note to return back, right? So you'd have a conversation with the patient as the provider, and the tool would take a few minutes to generate that note and send it back to you. Well, it turns out that wasn't a really great workflow for the providers because, as you know, they go from room to room and they're seeing a lot of patients during that day. So to wait 2 or 3 minutes for the note to come back means it's not happening while the patient's in the exam room. It's still happening after. And, the best time to complete that documentation and to confirm with the patient is all while the patient's still in that exam room. So it wasn't until last year, so about a year into the program, that we were able to improve that turnaround time to the point where the note really could be completed in the exam room while the patient's still there. But until you get down to less than 30 seconds to return that note back to the provider, the workflow doesn't operate as well as it could. So that was one of the lessons, and there are lessons like that across every type of implementation of this technology. You really need to take the workflow into account.
Yeah, and I like what you're saying too about you're you're not trying to apply the same workflow or the same process to everyone universally throughout the hospital, right? Like there are different needs, and I think especially when you get into some of the subspecialties. I had a dermatologist on the show a few weeks ago. She's created Derm GPT, and I learned a lot about dermatology through that conversation, right? Like when you are really deep in a specialty and the volume of patients that a dermatologist sees and kind of what they're doing, going over, head to toe, right, doing skin checks, whatever the specialty or subspecialty is, there are really unique things that happen in each of those office or clinic settings. And if you were to try to apply it universally and just give everybody one set of tools done one way, as you said, you're going to have some users that adopt it, raises the floor, others who are checked out because it doesn't do anything that they can't do today, or doesn't meet the needs, or how they develop some specialized templates when the EHR software pops up and they can kind of very quickly document what they need to do. So I think having a flexible approach, being agile with how you work with your teammates, right? And on the clinical side, especially, ultimately that's what your you're all there for is to take care of patients and offer a high level of care. But technology is an enabler. I think sometimes, technology gets a bad rap in a lot of situations, right? But, we know that there are some things that we must do. But if we look at it as an opportunity to give the team superpowers, right? How do we help them do what they do, but do it better, do it more efficiently, give them time back? Because literally, based on your simulation study, you said like there's not enough hours in the day to do it, right? Last week, I'll check, there are only 24, and people need to sleep and eat and have a life somewhat. Famously, medical students especially don't have a life, right? They spend all their days at the hospital and kind of going through it. But wouldn't it be nice if we could give them some kind of tools to help them regain control of their day?
Yeah, and make it a day that won't cause so much burnout. I think, there is a crisis now and a major workforce shortage, both on the nursing side and on the provider side. And it does feel good to, in a small way, make an impact on that situation. I mean, a 40% reduction in documentation time is significant. If we're able to, and I'm sure we'll be successful, move that same level of efficiency into the acute space and into the nursing workflows, it's really going to make a tremendous difference. And our clinicians are excited to do the work that they come to work every day to do. And it's not documentation. It's caring for the patients. And that's exactly what we're focused on.
So let's take the focus into nursing. As you look at the ways to partner with the nursing staff there and help support them with some of these initiatives as part of the whole vision project, what are some things that you're looking at? What's essentially low-hanging fruit that you might be able to go after? What's some of the more challenging things that you're looking at as well?
Yeah. As you mentioned, nursing workflows are fundamentally different from the physician workflows. And some of the technology has pretty good parity from a provider standpoint and a nursing standpoint, but many of it really doesn't. That sort of episodic into the exam room, dictate a note, or use the tool to generate your documentation and to generate your orders, and then that encounter's over, usually in the course of less than 30 minutes. That's a very different set of needs from a technological standpoint than an acute environment or an environment in an OR. But the core issue is similar, right? Just like we talked about providers not having enough hours in the day to do their job, multiple studies show the same thing for nurses. So, a substantial portion of their shift, more than half in many studies, is spent on documentation and non clinical activities. So, in addition to that, there's a whole lot of time spent looking for supplies and equipment. And between documentation and clerical tasks, looking for supplies and equipment, most estimates leave somewhere in the 20% range for time at the bedside for nursing. And I think that is a huge opportunity for our entire industry to leverage these types of technologies to change the relationship between the nurse and the EHR. And I think it's work that is long overdue. So, beyond clinical documentation, AI for nursing is going to enable a lot of functionality when the nurse walks into the room and is going to do a head to toe assessment, as an example. It's not the same as having a conversation with the patient. A lot of times the nurse has all the information and is looking at the patient and doing an assessment and then doing the documentation on their own. It's very often not verbalized. And what we've seen is you can't just take an ambient listening tool and put it in the room with the nurse and expect that you're going to get a full head to toe assessment documented in the right way, because nursing isn't used to verbalizing that part of their documentation. So what we've seen is that tools that allow us to use AI to search the record more efficiently and reduce friction in navigating the chart have a big impact. The task execution and doing things like a head to toe assessment can be powered by ambient, and they can talk through the observations of the patient or talk about everything that they would normally want to document. But it's not quite the same as in an exam room and a conversation between a provider and a patient. What we've seen and what we're preparing to roll out in the next few months is a AI assistant that runs on a mobile device that we've deployed to all of nursing, but it essentially is a co-pilot that can help them do their rounding and do their documentation, but also is a shortcut for them to be able to retrieve things from the chart.
Yeah, that's interesting. Yeah, I think because my wife is a nurse and she's worked in both the hospital setting and other care settings as well. But there is something kind of about the verbalizing their observations and their assessment that I know from speaking to my wife. There is a hierarchy, obviously, in kind of how the licenses work, right? A nurse works under the license of a doctor. The doctor can go in and say whatever they want. They can see something and say, "Oh, that looks really bad," or something like that. A nurse would never say that because it's not a nurse's role to diagnose, right? They are there to assess, they are there to treat, they are executing the orders, whatever's been ordered by a licensed physician, or in case of nurse practitioners, physician's assistant. So obviously a lot of different licenses at this point that are common in healthcare, but yeah, it's literally not their position to say things out loud that a patient might say, "Oh, is that bad? Is that good? Is that well?" It's really not for me to say. The doctor will address that when they come in and see you, or whatever it is. So it may seem simple and kind of like, well, why can't you say it? But I know, again, from my wife and what she's taught me over the years, nurses have a very specific role, and it's a very broad role as well, of course, of what they do. But it is very kind of nuanced in terms of what they do and how they do it. So again, I think the big takeaway is you're looking at your populations of users for the various tools that you have available to you as the IT organization to bring into the hospital, and you're being really thoughtful about what you offer and how you partner with them to help support them and give them tools that will address their needs, but not try to force them into everyone into a common mold, or to a common way of working. So I think that's a really smart approach. Let's turn the focus a little bit away from the bedside and the clinic environment. I know you're also thinking, you do partner with Oracle, which has that unique ability of having both the EHR as well as ERP all in kind of one offering there. How are you thinking about those opportunities, maybe around revenue cycle and some of the AI work that's available to you there?
Yeah, healthcare has made incredible advancements over the past decade. But the reality is that most health systems still operate with deeply fragmented business processes. So the supply chain system, the HR system, the rev cycle system, many times some of the ancillary systems and the EHR largely function in silos. I started my career as a interface programmer, 20 some odd years ago, 26 years ago, I think, and built those connections, right? I built the connection from the registration system to the EMR and to the HR system and to the revenue cycle system. I made the beginning of my career was building those integrations. But the existence of the team, it's a whole team of people that builds those integrations because the environment is so fragmented. So we have a very complex data architecture in healthcare. And from my perspective, it's the most complicated industry from a technology standpoint. There's a lot of opportunity to standardize. So one of the projects I'm really excited about is part of Vision 2030 under accelerating transformation is deploying the new ERP platform from Oracle alongside of the Oracle platform we have on the EHR side. So we'll have one system over all of those different areas in our health system and really be one of the first to have those fully integrated end-to-end connections between all of those domains. So that program's really exciting. And I think it unlocks a lot of functionality and a lot of proactive analytics that we're going to be able to do. And it represents a real significant opportunity for the marketplace to do the same. I think that there are a lot of health systems out there that would benefit from simplifying their application stack and picking their key partners and sticking to it. I think there's a lot of best of breed environments out there in healthcare. I've worked in many of them, and there's benefits to that. But at the end of the day, you end up with a pretty deeply fragmented business, and all of your different aspects of your business, which are all really important, will remain to some extent fragmented to more of a single platform strategy. It is really exciting. We've had some early measurable wins with the program, but we're about halfway through a 6-wave rollout with the next one coming up in about 60 days.
Yeah, I think having seen these waves over the course of our careers, right? There's kind of the consolidation that happens, and then there's the proliferation with many tools, especially in this AI era. It's got to be tempting. I'm sure that vendors are calling you nonstop and sending you emails nonstop, trying to pitch the new, small niche tool for whatever it is, right? And everything is AI enabled, AI related at this point. And I'm sure that a lot of those are really appealing, but if you have more of a platform approach that you're trying to take with a consolidated set of partners to work with on the technology front, you have to make decisions, both for the short and the long term and try to balance the risk throughout it all, right? I think there's a ton of pressure, as you know, as a hospital CIO, just trying to manage risk. And usually introducing any kind of change just introduces risk. And so how do you think about balancing that with the variety of tools and this kind of platform approach? How does risk factor into your thinking?
Yeah, I think that's a great question, and something that we're increasingly thinking about as we're in an environment now where most of the vendors that we are working with have now modules of their application that are, AI powered. But in order for it to work, you've got to ship all your data, out to their LLM, and which ultimately usually is third party. Many of them go to one of the big 3 or 4 anyway. But all of that data now is going over the wire and leaving our network and, making its way through a data center that I don't control, and then coming back with a response or a summary back to our environment. And the way that we are thinking about it, we are sort of, creating more of a platform strategy. All of the AI tools that we have planned deployments for come directly from Oracle. And part of the benefit of that is it's all within one stack. So we don't have calls all over the place. We don't have data going all over the place. We know exactly where it's going and we know exactly how it's protected. And another one of the benefits of having that platform strategy is a reduction in those point to point integrations that you need to build out in order for these systems to work. The capabilities of a lot of these new systems powered by AI is really exciting and it's compelling, but taking data security and taking your architecture and how your architecture and security go together is something that I know a lot of CIOs are thinking about, particularly the long-term implications of that.
Yeah, I think for those of us who watch the show The Pit on HBO Max, right? They, you know, uh, to avoid a cyber attack that was hitting other hospitals in Pittsburgh, where the show is set, they literally shut off their computers to avoid it and went to paper-based, going old school, as we would say. So these are not just stories that are in television shows, but they're unfortunately in the news as well. So the risk is incredibly real, and uh, and I'm sure it keeps you up at night. But I think this idea of consolidating and really kind of having a platform approach to this, and an understanding kind of from a data security standpoint, where is your data going and who has access, who handles it, all of that. And not having to worry about some of the integrations you would have if you had a million third parties and a million kind of bolt-on tools, that many struggle with. As we wrap this up, if you think about your colleagues and your peers in the industry who are looking at some of these AI pilots and kind of pivoting from the pilot stage to real usage, where do you think they should start, and what advice do you have for them?
Yeah, I would recommend starting with the use cases and start with the metrics. So there is no shortage of agents and tools out there right now. And as you mentioned a bit earlier, many of them are very kind of niche focused. They have one or maybe two things that they do very well, and they own the market in that space. The problem is there's 1,000 of those. And I think I would recommend that organizations start with the use cases and how they're going to measure it. And involve the clinicians, involve your operators, make sure that you all understand what those priorities are and how you're going to measure it, and then go find the tool that's best going to solve that problem. If you end up just sort of, like many of us have our ear to the market and we know where the latest trends are and what new applications and tools are available, I think sometimes you end up trying to solve for problems that aren't really on the top five of your organization. My recommendation would be start with the use cases that are most important to your organization and then go find the solutions and do so with your operators and with your clinicians at your side. So you all agree on what the priorities are. For us, it was documentation time. And that's really where we're going to remain focused, making that experience more efficient for our providers and easier for our patients to interact with us with.
Yeah, that's great. Yeah, I think it's easy, especially as you say, with your eye and ear on the market, at HIMSS, or I was at Becker's last week in Chicago. Every event conference, there's a million plus all the phone calls and emails and web ads, and I'm sure everything that gets served up to you. It's easy to let the tools kind of guide you into, and some of them are really captivating and really interesting and those kind of thing. But if you don't have that prioritized set of use cases to compare it to, it's a bit of the tail wagging the dog, right? So, having that focus and being aligned organizationally, right? It's not just about what's an IT priority. If you're playing your role well with the rest of the organization, you're supporting their needs. And it's nice, again, that you've come together as a system on your Vision 2030 to know not just Vision 2026, what are we trying to do this year, but having a little bit longer term of a view about what you're all trying to do and what role does technology play in that. And obviously, AI is one technology. Seems like it's taken over the world and it's the only technology, but the reality is it's one of many tools that you can bring to the table to help support the growth of the organizations. I think a lot of interesting lessons to be learned there. So, Jordan, thanks for the time and the conversation. This was great.
Yeah, my pleasure, Mike. Good to talk, and we'll hopefully do it again.
Yeah, sounds good. And thanks everyone for listening. If you're working on reducing admin burden or improving how your teams operate, it's exactly the kind of work that matters right now. So keep at it. Listen to the wise advice here from Jordan, and we'll see you next time on the Health Tech Edge.